Good evening and hello, everyone. Welcome to NCUI's High Performing Boards in a Virtual World, the board's role in safety, quality, and compliance. This is our third and final evening in the board training series, and we're glad to have you on board. Next slide. To begin, we have a background on NCUI. It's the National Council of Urban Indian Health. It's a national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives living in urban areas. NCUI is the only national representative of the 41 Title V UIOs under the IHS in the Indian Healthcare Improvement Act. NCUI strives to improve the health of over 70% of the American Indian Alaska Native population that lives in urban areas, supported by quality, accessible healthcare centers. Next slide, please. Again, welcome. We'll start with quick introductions and then delve into the board's role in safety, quality, and compliance topic. We'll conclude with the Q&A discussion and provide NCUI's upcoming events to register for. Our closing session will feature a wrap-up discussion and closing thoughts. Next slide, please. This is housekeeping information. Before we begin, please note that this session will be recorded for educational and quality improvement purposes. NCUI will be utilizing the recordings to continue to share and educate frontline healthcare workers throughout this pandemic. All mics have been muted. Please turn on your camera and to allow for interaction. This is a 45-minute session and questions can be entered into the chat box. A Q&A session will be offered at the end of the session, and slides and recordings will be available at the landing page for our board training in the NCUI homepage. There'll be an evaluation to follow at the end of the session, and of course, we welcome your feedback. We really depend on your giving us feedback regarding to the quality of our trainings, so we can always focus on improvement. If you have any IT difficulties during today's call, please chat directly to the comms and events in the direct chat, and they can assist you. Finally, if you could please enter your name, your UIO and external organization, and any tribal affiliation into the chat box so that we can get to know each other and count your attendance. Your feedback is really important to us. A little more housekeeping detail. How to ask your questions or comment. To ask a question in the chat box, select chat at the bottom of your Zoom screen. Then type your question or comment into the chat box that will appear on the right. Now I'd like to present or introduce our presenter this evening. Our presenter is Zepporah Fuller. She's the Director of Technical Assistance. She earned her Master's of Science in Healthcare Administration with a concentration in education, and is a certified professional in healthcare quality. Zepporah has more than 13 years of experience working within a variety of healthcare delivery systems. She is a committed servant leader for Indigenous communities and helps organizations build capacity to improve quality care. She has served in various roles that include front office management, data informatics management, accreditation preparation, billing and coding, and quality improvement assurance. Ladies and gentlemen, after our knowledge check questions on the next slide, the next voice you hear will be tonight's presenter, Zepporah Fuller. The knowledge check slides will last for approximately 60 seconds beginning now.
Okay, great. Thank you so much, Mark, for facilitating the introduction for me and also getting the knowledge check questions together. So today, everybody, I wanted to go over the board's role in quality, safety, and compliance. And so today's objectives, next slide, please. We're going to go over understanding why quality, safety, and compliance is important. I also threw in some really great tidbits in here that pertain to the Indian Health Service and triple AHC competencies. More specifically, again, focus on governance and quality. We're also going to understand the difference of quality assurance versus quality improvement versus performance improvement. We're going to go ahead and identify some board of director quality reporting elements as well. Next slide, please. So before we began, I wanted to just go over the quality history. As Mark had mentioned, I do have a CPHQ, the Certified Professional in Healthcare Quality. And so for me, this is such an important topic for all of us to understand and ensure that we do know where the history stems from. So the National Academy of Medicine, formerly the Institute of Medicine, called for profound transformation to improve the culture of patient safety in 2 landmark reports. So the first report, which is linked here, is to err is human, and it asserted that the problem is not bad people in healthcare. It is actually good people that are working in bad systems that need to be made safer. It also broke the silence that had surrounded medical errors and their consequence by not pointing fingers at caring healthcare professionals who make honest mistakes. Instead, the book actually sets forth a national agenda with state and local implication for reducing medical errors and improving patient safety through the design of a safer health system. It also does explain how patients themselves can influence the quality of care that they receive once they check into the hospital. It's also important to note that the book is vitally important to federal, state, and local health policymakers and regulators, health professional licensing officials, hospital administrators, educators, students, caregivers, journalists, patient advocates, and patients themselves. If you guys have not had a chance to read it, I would highly encourage you to do so. The next item that is listed here is crossing the quality chasm. And what it does is it makes an urgent call for fundamental change to close the quality gap. It recommends a sweeping redesign of the American healthcare system and provides overarching principles for specific direction, again, for policymakers, healthcare leaders, clinicians, regulators, purchasers, and others. Analyzing the healthcare organizations should be done as complex systems. You should recognize them as complex systems. It also documents the causes of the quality gap and identifies current practices that impede quality care and explores how systems approaches can be used to implement change. These reports accelerated the pace at which healthcare systems began to understand and implement changes and improve quality and the safety of care. Our focus today is on the second bullet point, which is the year of governance, an article that was published in the Joint Commission Journal on Patient Quality and Safety. And that was written by Dr. Donald Berwick, who is the former president and CEO of the Institute for Healthcare Improvement. That report added urgency to the need for transformation, placing responsibility for the proper stewardship of healthcare with Health System Board of Trustees. So rather than have staff place that responsibility solely on themselves, is a shared responsibility as governance, as board of directors. He indicated that leaders need to own governance for improvement to take hold. And that's what today's session is going to focus on, is your role as the board in quality, compliance, and safety. Next slide, please. So what I wanted to open with are 2 stories as to why quality and safety and compliance are important. There is a quote here by Linus Alcoriza. How can we get the right information to family caregivers so they know how to navigate the system and the language they understand? And I thought this was just a phenomenal patient testimony that really ties to some of the I want to say hurdles and challenges that we face for care coordination. So here's her story. I've worked in public sector managed care for the last 30 years and consider myself pretty knowledgeable about the healthcare system. But I found from helping my mother, father, and one of my brothers that it's very difficult to navigate the system when you are low income, have multiple medical necessities, and face a language barrier. Growing up in Puerto Rico, my family received healthcare through Medicaid. I moved to the States 33 years ago for college and stayed here and got married. I later brought my parents and my brother to live with me in Virginia Beach, Virginia. They continue to receive Medicaid and Medicare. My parents, Gloria and Herminio, don't speak English, while my brother Jeffrey understands English but can't communicate very well. The system is not equipped in geographic areas like Virginia Beach that aren't heavily Hispanic to serve Spanish-speaking people and explain treatments and benefits. So I'm the only one who goes on appointments and tries to do coordination for my entire family. I have to be available for everything. Because of my job and my work travel, it is truly a struggle to be on top of all of their appointments, case reviews, and other medical issues. On the hospital side, they do offer Spanish translation services, but here in Virginia Beach, I haven't been able to find a doctor for my mother's special needs who speaks Spanish. When the doctor prescribes an extra medication for her, if I don't pay attention, she'll be doing double doses on everything. A year ago, the doctor prescribed a generic version of the brand name blood pressure medication she was taking. For about a month, she was taking both prescriptions. I was able to cut it off before she suffered any harm. When that happened, she was seeing doctors in different provider networks. My father, who's divorced from my mother, suffers from chronic depression. He couldn't find a local mental health provider who spoke Spanish, and he didn't want to talk about such private issues through a translator. We found a doctor in the Washington, D.C. area who spoke Spanish and could treat him. For 2 years, I drove him there once a month. It was a 4.5 hour round trip. 6 years ago, he moved back to Puerto Rico because of the lack of access to a Spanish speaking mental health provider. My brother, who's 47 and has had 2 strokes, can understand what the doctors say, but it's hard for them to understand him. Whenever he has an appointment, he tells me what he's going through, and I write it down for him to give to the doctors in case there is no translator. Think about all the multiple languages spoken in the United States and all the people who have problems with care coordination and quality of life just because they don't have access to healthcare in their own language. While they were growing up, my children saw the needs of low income people who come from a different culture and speak a different language. Maritza is a social worker at a center serving predominantly Hispanic children. One of my sons, Oscar, is a third-year medical student who wants to be able to use the Spanish language to serve his patients. There definitely needs to be an acceleration in progress. How can we get the right information to caregivers so they know how to navigate the system and the language they understand? It is a very complex system. And with that story, I feel like so many of us can identify with that, receiving care at an urban Indian organization, and then also, going to an Indian Health Services hospital as well. Care coordination is one of those areas that we definitely can do better in. We do know that the RPMS system also does not allow for interoperability. So also really trying to think through how can we provide our patients with the best care coordination possible, knowing the limitations that are on our systems. So again, that is also why quality, safety, and compliance is so important. The next story that I wanted to share with everybody comes from Dr. Donald Berwick, again, the former CEO of the Institute for Healthcare Improvement. And so his story is also very profound because it talks about when things go right, when everybody is all hands on deck, everybody is stepping up to the challenge of providing quality care. And this is his story. My youngest brother, David, almost died last March. It started as a fever, but in a few hours it had become a raging case of sepsis from Legionnaire's disease. His organs began to fail, and the academic medical center where he had been admitted rushed him into the ICU. We were sure we were going to lose him because recovery rates from adult respiratory distress syndrome, acute renal failure, and overwhelming sepsis are not high. Once in the ICU, technology took over David's failing organs. It was a convergence of magnificent biotechnology. Most impressive was the care team itself, consisting of 20 or 30 people, doctors, nurses, pharmacists, technicians, who seemed ever present at David's bedside. The ICU team had a method for complete coordination of their efforts. Several times a day, the entire team huddled just outside David's room with a half a dozen computer screens, paper graphs and charts, protocols and checklists. Amazingly and movingly, they included our family in all of that. They treated us completely as partners in David's care. Everyone had a voice, including the student nurse. The lowest points for David came on days 4, 5, and 6 when each managed support was pushed to its limits, and we waited for the moment when there was no more room to push in oxygen, no more reserve in his heart muscle, and no more hope that his kidneys would return. But then, little by little, the graph started to change and the lines turned upward. On the 9th day, they pulled out his breathing tube and reduced his sedation, and David opened his eyes. 3 weeks later, he returned to work as he had beaten the odds. The more I think about it over the past few months, the more I believe we and the healthcare system have moved away from quality improvement as the core agenda. If we redid the classic quality studies of the past several decades today, I'm pretty sure the results would be about the same as when those studies were done. That's a serious indication of complacency. What saved my brother wasn't telling people that they weren't trying hard enough or using pay for performance or tighter enforcement of rules. It was measuring, learning, customizing, and everyone working together and taking pride and joy in their work with a single shared aim to save David. The job we have now is to take what we now know about the roots of excellence, the same roots that saved my brother's life, and as healthcare leaders, clinicians, government officials, and patients, we should use those principles to guide our action together. And with that, that was Dr. Donald Berwick's story. I thought that it was just so moving, and everybody just had, again, they knew exactly what was done. And it also does showcase the need for policies and procedures so that everybody is moving at the right time and the right way because it's the right thing to do. Next slide, please. Again, continuing on why it's so important, as we know, healthcare quality and patient safety are deeply connected. You cannot have one without the other. Quality healthcare is care that is safe, effective, patient-centered, timely, efficient, and equitable. Patient safety is also a very, very important aspect of healthcare quality and is also a key priority. One of the things I like to infuse in the safety definition as well is the inclusion of staff, keeping each other safe, ensuring that everybody is paying attention, everybody is, again, all hands on deck, and everybody knows exactly what their role is. To ensure patient safety, healthcare systems must strive to prevent errors, learn from the errors that do occur, and create a culture of safety that involves healthcare professionals, organizations, and patients. Next slide, please. As we know, again, quality and safety are guided by regulatory agencies. When we think of patient safety, a key takeaway is that a lot of the emphasis is placed on the system of care delivery, and that includes the need to prevent errors, the need to learn from the errors that do occur, and building a culture of safety that involves, again, the healthcare professionals, organizations, and patients. Some of the regulatory agencies that do require the same approach are CMS, the HHS as well, HRSA and IHS, as many of us are more familiar with, state health departments, and as well as OSHA. One of the most influential framework that is put forth by the Institute of Medicine, which we are all familiar with, includes the following 6 aims for the healthcare system, and that is the STEEP framework. So the S, as you know, is for safe, avoiding harm to patients from the care that is intended to help them. T, timely, reducing waits and sometimes harmful delays for both those who receive and those who give care. It's also effective, providing services based on scientific knowledge to all who could benefit, and refraining from providing services who are not likely to benefit, which is including avoiding underuse and misuse. It's also efficient. You got to think about things like avoiding waste, including wasting supplies, equipment, energy, and ideas. This also includes meetings. Sometimes we meet just to meet. And so really trying to have set agendas to where we can come together and build productive systems and workflows. It's also equitable, providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, and socioeconomic status. It is also patient-centered, providing care that is respectful of and responsive to individual patient preferences, their needs and values, and ensuring that patient values guide all of our clinical decisions. Next slide, please. And I wanted to just take a quick moment to pause and take a look at everybody and also give the group some time, a moment to chat box in, or you can also come off of mute. This is your time to share strategies, things that you're going through. Others want to hear from you and learn from you as well. So Nikui is also here as teachers and learners. So we'd really love to hear about what are some of the required governance standards or competencies that you guys can put in the chat box for us to take a look at. What are some that you guys are working on now? What are some that you worked on before? Again, what are some governance competencies or standards that you can throw out there? And they could be standards from IHS, they could be from HRSA, from CARF, from the Joint Commission, NCQA. What are some standards, folks? I know we do have a group of UIO members currently who are reviewing their infection control and prevention policy right now. And so we're helping them out, trying to identify areas of opportunity and also include other requirements for the triple AHC as well as the OUIHP site visit manual as well. So here's a list of some of the IHS governance competencies, in addition to the pages that are listed here for pages 41 and through 45, which is the, again, governance section. Oh, thank you, Mary. Research and evaluation policy. That's, I feel like the biggest key thing right now in Indian country is that, I don't know if yours involves the IHS internal institutional review board as well, but I feel like a lot of folks are now reviewing their IRB policies more often and more recently as of this year in light of the COVID-19 pandemic as well. So thank you for that. So as mentioned, these competencies are pulled directly from the governance section. Some elements that are required, as listed here, is the board composition. So they do require makeup a set board makeup of 50% of your board should be American Indian or Alaska Natives and also reside or receive services from that urban Indian organization. You also want to make sure that you have UIO operational and performance policies in place, and this can pertain to financial policies as well. You also want to make sure you have a specific event review policy that's in here in which you're reviewing any criminal indictments, proceedings, or guilty pleas. You also want to ensure that you include meeting frequency minutes for your board of directors as well as standing committees. In addition, you also want to take a double look at your last accreditation survey if there were findings there. What are some of the things that you guys are working on as you're implementing improvements as it pertains to, again, those findings? You also want to take a look at your OUIHP site visit results so that you guys are being very mindful and strategic and working on the same goals at the same time. They'll also require that the authority, responsibility, and functions of elected and appointed positions are defined. So this would lend to the position descriptions that are created, and also ensuring that the UIO director is selected by and is responsible to the governing body. Next slide, please. So now we want to go into the triple AHC governance competencies. And again, you'll notice that this is more focused on the OUIHP IHS site visit as well as the triple AHC, just because we have more urban Indian organizations that fall under both of those categories as well. So for the triple AHC governance competencies, and thank you so much, Jeff Axtell from NAGA, for putting in there the employee vaccination policy to include COVID-19 vaccines. That is a big one. Vaccine policies have also been on the rise and increase infection control plans. So thank you guys so much for that. We do have on the line Evelina Maho, who is our research and public health manager as well. And she is leading our CDC IPC group. And so I'm sure she'd be delighted to also hear about some of the work that you're focusing on so she can take that back to her team as well. So thank you. So the Triple HC governance competencies is an incredible organization, or requires that an incredible organization has a governing body that sets policy and is responsible for the organization. Again, we're looping back into that very first slide at the beginning about this is the year of governance. Board of directors are definitely on the hook, or I should say on the leadership hook, for ensuring the organizations move in the right direction. In the Triple AHC Accreditation Handbook, version 41, Chapter 2 talks all about governance requirements and elements. You'll also see it infused throughout the handbook and other chapters as well. What they like to focus on is looking at your strategic direction, looking again at your board of directors meeting minutes and logs and when those happen. Also looking at your policies and procedures. They'll also be looking at your operation and performance as it pertains to the organization, inclusive of the financial management and accountability. Moving back up one, they'll also be taking a look at your credentialing and privileging practices. They'll also be looking at your risk management, infection control, and quality plans. And they'll also require some of your policies either be reviewed annually. Some of them also are meant to be reviewed triannually as well. So just keeping that in mind. Next slide, please. So moving from the must-dos, moving into this is what your organization must do and to how to do it, we're going to move into the discussion about quality assurance, quality improvement, and performance improvement. As I mentioned before, each of these three focus areas are very different. Quality assurance has a focus on compliance with current standards and practices as you define it in your policies, procedures, regulations, and professional standards. Quality improvement focuses on more of the systematic and continuous actions that lead to measurable improvement in your services and in the health status of your targeted patient groups. Performance improvement focuses and compares your organization's performance in relation to a specified process or outcome. You guys have all seen the GIPR reports come out, as well as the SDPI and some of the Indian Health Service UDS reports and HRSA UDS reports. So those could be considered benchmarks once you look at your internal organizational performance. So that is where that quality improvement and performance improvement would come into play. Next slide, please. And so now we are stratifying and extrapolating quality in and of its own out from safety and compliance. So why do we want to take quality seriously? It's because it's the right thing to do. A lot of us also have it in our missions to provide quality care or quality services. It also helps to proactively prevent harm to your patients, staff, and guests. And as a board member, again, you do have that legal responsibility. You also need to ensure that quality care is provided, and you also should be ensuring that organizations have processes in place to measure and deliver quality care. Your organizational roles and responsibilities should be clear, and it's also a great way to think of yourselves as champions and that you provide support to your wonderful organizational teams. Next slide, please. In the IHS Quality Competency world, the Office of Urban Indian Health Programs On-Site Review Manual includes the patient safety and quality competencies. So they require that you have a quality assurance performance improvement plan complete with activities that you're going to be working on. They also do require that you complete a patient and community satisfaction survey. They also do ask for benchmarking reports, or I should say a benchmarking methodology, along with a rate of compliance. They also do require board reporting for your QA and QI standing committees. They also do take a look at a culture of safety and quality. So they'll also want to take a look at your risk management and infection control plans. They'll also want to know how you are reporting clinical events within your organization and how often and what sort of staff education and training is being provided. The image that is embedded in here is the Institute for Healthcare Improvement Model that they also like to see in their improvements methodology. So they like to know, what are you trying to accomplish? How will you know that change is an improvement? And what changes can you make that will result in an improvement? And you'll see that they follow that PDSA model. Next slide, please. So here are the IHS models to improve care. So on the right-hand side, you'll notice that there's the IHS Care Model. And so that is a really great way to think about the fundamental changes in the IHS system of care that are required to achieve new standards of care. So that IHS Care Model incorporates the following key elements, which is the anytime access to the care team. They also embed a well care and sick care in addition to preventative and chronic care element. They also include high quality, reliable care, coordinated team-based care, and in order to achieve this, the following foundations support the care model. So they do include the community involvement and engagement. Healthcare quality improves when this entire community is engaged and works together to improve overall health. They also have included as a foundational element the cultural and spiritual respect. IHS recognizes cultural and spiritual respect as crucial components of healing. They also mention an integrated clinical information systems, which that includes the medical record systems, multiple information sources that are used by the care team to ensure that holistic approach. Healthcare quality improves with the combined use of EHR and patient management systems. They also note the last foundational element of engaged leadership. Healthcare quality improves as facility leaders embrace improving patient care and focus staff energy on improvement work. One of the questions that was asked earlier was if the IHS Care Model includes the inclusion of facilities, and that answer was false. So I just wanted to throw that out there really quickly. You'll notice the IHS Care Model does not, again, include the facilities expansion. Moving into the next, to the right of this slide, the change package. This is another very important update in the IHS quality realm, is that they look at the number one is laying your foundation, having your QI strategy ready, using that engaged leadership. Building off of that, you move into your building relationships, having that continuous team-based healing relationships element, and also provider empanelment. So again, really understanding that your care provider who is coming into your room, you have an established rapport with that person, as well as your care team, your medical assistant, your front desk receptionist as well. Moving off of that, you then move into changing care delivery, how you have a patient-centered, how you host patient-centered interactions, and also organizing and using evidence-based care models. And then on top of that, once you build the foundational elements, that's how you start to reduce barriers to care. That's when we can start focusing on care coordination, as our previous story had mentioned, in addition to increasing enhanced access to care as well. So this is a really good, slide for you to review, just as a refresher if you've not already. Next slide, please. Some of the triple AHC quality competencies are also found in their version 41 handbook. There's explicitly listed in chapters 4, 5, and 7. So they will also require that you review your policies and procedures in a timely basis. They'll also look to see if you have MOUs and MOAs in place, and try and understand what sort of contract procedures that you have in place for care coordination. That does include the delivery of care. So they'll ask for your after hours policy, your referrals policy, and again, your coordination of care policy. In addition to that, as you all know, they will require a time frame as to when these referrals and coordination of care inquiries can be closed out. They'll also require that same QAPI plan, as you notice in the IHS OUIHP requirements. They'll also require that QI program plan and activities. They'll also take a look at how you benchmark your organizational performance against other organizations. They'll also take a look at your board of directors reporting, and also the risk management, infection control, and safety, facilities, and environment policies. Again, they'll also want to learn how you report clinical events, as well as how you incorporate staff education and training. Next slide, please. So this slide, if you take away anything from today's session, it would be this slide that has the QI studies and the 10 elements. It really gives you a breakdown as to how you guys can complete quality improvement activities within your organizations. So this again is a requirement by the triple AHC. On page 184 of the version 41 manual, again, it'll lay out the request to list the purpose of the study. It'll ask you to identify the performance measures, goals, and objectives. It'll ask about the description of the data that you're hoping to evaluate and analyze. They'll also want evidence of the data collection and the data analysis. And number 6 is usually where some folks also get tied up on, the comparison of current performance versus previous. A lot of times people will say, oh, well, we just got the same outcome, even though our goal baseline was to improve patient wait time by 10%, we hit 7, we're good. I mean, we increased from 5%, the QI study is done. That is not the intent for the QI study. So once, if and when that happens, you want to go back to your quality improvement team and do a cause and effect diagram. Find out what the bottleneck is, how come you're not able to achieve what you had set out to do. And counter to that, if you were like, we're going to reduce patient wait times by 100%, then at that time you would warrant a moment to say, okay, maybe it wasn't realistic. Let's see if that is, an unrealistic goal. So it's really meant to be a point of an approach in which you can reflect change up your procedure and strategy. And the AHC actually has a roadmap within their handbook that actually gives you a decision-making map. Do you have data? Yes, it moves you to the next point. Is your data quantitative or qualitative? And then you take that route to the next bullet point or step. So it's really important that you guys take a look at that. Even if you're not AHC accredited, it's definitely worth a glance at for sure. And then that number 7, implementation of corrective actions. They will ask and see if you have remeasured the problem objectively. So also listing when these QI activities would be closed out is also another, I want to say, area of opportunity that UIOs also tend to have. And that includes, like, if you have an additional corrective action, if you said, well, in 6 months, we're going to reevaluate our patient wait time, but you ended up reevaluating it 9 months later, they're going to want to know what happened, what transpired between that time, to really ensure and get a good glimpse as to how the organization does run. The good thing about the AHC is they are not so much as they won't like ding you just to ding you. I mean, they're there for questions that you might have, answers. They're a learning organization, so they're there to help out and help address any QI, I guess, challenges and barriers that your organization might be facing as well. Number 10 is the most important bullet point to remember for you as board of directors. HHC does require that the QI studies do get reported to the board of directors. So you guys should be seeing those coming across your desks if your organization is AHC accredited. Next slide, please. So as we move into more of the board role and what it looks like as it pertains to quality, safety, and compliance, it is good to know that your role does include the following functions. So we go into the legal function, in which you would advise the organization on the legal and regulatory risk of its business strategies, providing advice and counsel to management and the board about relevant laws and regulations that govern, relate to, or impact the organization. The function defends the organization. The function also defends the organization in legal proceedings and initiates legal proceedings against other parties if such action is warranted. And again, that would come from any attorneys that your organization might have. If you guys might need to consult on, a particular action. I know sometimes patients might need to be dismissed from a health center because maybe they're not very friendly. Maybe sometimes they cause commotion all the time and are just always disgruntled. Sometimes it's tough to know when to dismiss that patient from the practice. So it's a really good example of, when to consult with an attorney. So again, just one example of when they would be tapped for that. The role for the compliance function is your role is to prevent, detect, and resolve some actions that don't conform to the policies of the organization. So the obligation for you is to develop policies and procedures that provide your employees with guidance, and the creation to also ensure that there's no repercussion or hostile work environment creation if an employee, is going under what's the word, like a performance review, or if there is a moment in which that staff member might have been the cause of, let's say, like leaving a sharps container like open instead of closed. I know that for the clinicians out there, usually they have a line on the sharps injury container and it says do not fill above this line. And let's say I was to be that person who just stuffed it full of sharps needles, rather than going with the culture of, this is bad and, slapping my hand, looking at it from a perspective of, again, a just culture, understanding why that happened. Why did that occur? Is it because I didn't receive adequate training? Is it because maybe my mind was elsewhere? Is it because that's normally not my role in that day? I was just filling in for somebody. So really taking a look at the bigger picture and getting all of your ducks in a row, so to speak. The internal audit function, that provides you guys with an opportunity to look at your policies, procedures, workflows, again, to ensure that the organization is doing what they said they were going to do in the manner that they said they would in the policy. One organization that I was at actually had gotten dinged by HRSA because in their referrals policy, it stated that we would refer patients out and follow up with the consulting provider within 1 week. And it turned out some of those patients were being followed up on about 3 weeks out. So again, that would be another major finding. So really taking a look and ensuring that whatever times, dates that you set in your policies, performing that audit on those is going to be another role in which you could ask your organizational staff members, what that looks like. Another key element too is also touching on the human resources function. So also taking a look at coordinating some of the higher level like C-suite roles, taking a look at if folks are in there to try and maybe hire like a CIO. Also really trying to ensure that you incorporate that element as again an HR person. Quality improvement, and this is again the key role here. Always looking to improve, always looking at why maybe patient wait times are, long, maybe why patient complaints are coming in more frequently than before. You should also talk about and evaluate how management works together to address risk. So again, identifying those compliance risks, you guys should be receiving a risk assessment at least monthly, just based off of some of the elements within your organization, whether it would be, leadership rounding. It could also be a risk assessment rounding if you have multiple sites. Also looking at how you're going to investigate compliance risks and also avoiding duplication of effort on behalf of any multiple locations that you might have. But more so communicating between the various functions as well. And those functions also listed at the top throughout your board of directors tenure. Next slide, please. And so we're just gonna move into another group feedback discussion. You can chat in the chat box here, or you can also come off of mute, but we wanted to know what kind of data you get as a board member, kind of shifting gears here. Now that you've got your role, what does it look like? How do you as a board member function in your role when data is presented? Like what sort of data do you guys get? And again, feel free to chat in the box. And we can also move into the second question as well. What do you like and what don't you like about your data and about some of the reports you're getting? What are some areas of opportunity there? I know for an organization that I was working with as a consultant, they received big chunks of data and it was just a screenshot of dashboard after dashboard after dashboard. And they had preferred more bulleted points versus having to look at tons of data. And mind you, some of our board members were, not in that statistician realm. And some of them, were operating food banks. So again, really trying to understand what your organization looks like and what kind of data would be pertinent to them. Another sort of data set that was an area of opportunity were also very long narratives. So if the point that needed to be made was just, we saw a trend in, or I should say a decrease in breast cancer screening rates. It was a long narrative about, breast cancer month, how they wanted to focus on that in October, and it was, I believe, March. Also trying to see about what's relevant and also what would be appropriate for that reporting time frame as well. And having seen no responses, we can go ahead and move on to the next slide. So as mentioned, an effective board quality report should be timely, should definitely be received regularly, again, should be relevant, should also be integrated with other tools or methodologies. So you do want a good mix of quantitative and qualitative data. Should also be reliable, again, including up-to-date information, objectives, and appropriate, sorry about that. I left that, it would be appropriate information. You also want to include your short and long-term goals. You also do want to include any performance metrics that you guys have identified as working to. You also want to include some compliance and risk information. So if there was a sentinel event or a near miss, you guys should also be made aware of what that was, how that occurred, and what the mitigation strategy is going to be. You also want to use those to facilitate decision-making amongst your team, as well as with leadership of the organization. Next slide, please. Some of the things to keep in mind during the quality improvement review as you guys are looking at those activities is to keep in mind that you will be providing the motivation and the direction for your team's quality improvement goals. You'll also be helping to identify gaps in services or overuse of services and potential areas for improvement. And this is why the board, I'm sure that you sit on, is very diverse. I'm sure you also have different individuals coming from different industries, and that is your time to make a comment, think about how this could be applied innovatively outside the box, as well as really trying to, again, as that third bullet point alludes to, allow practices and teams to track changes in performance over time. I know that for our one of our board members was a nurse consultant, and she provided a lot of really great oversight on some of our QI studies, having had that background. We also had a individual who was in finance for, I believe it might have been Pepsi or Coca-Cola. And so she also provided some really good financial strategies to help the financial team improve their performance as well. So really take a look at what sort of skill sets you guys can share, what sort of thoughts and strategies you could or ideas you could implement too. Some of the things that you can ask for as a board member during a QI review that the team should already have on hand ready to go would be data feedback and scorecards. So we used to have a daily huddle in which we would go over the financial scorecards as well as billing. And so we had the number of visits that were billed, how many bills were denied, how many of those had gotten worked out, how many patient complaints we received, how many incidents that had occurred, how many QI studies were closed, how much money we had on hand. So in addition to that, we had a really great scorecard on hand. We also did take a look at corrective action plans, and you guys can ask for that as well. We know that for OUHP, anytime they come, they will give a finding report. So taking a look at how often your what I would call a multidisciplinary team is looking at those corrective action plans and implementing those improvements. You can also ask if they're involved in any shared learning collaboratives or shared learning or learning collaboratives. I know that the state of Arizona has a primary care association with the Arizona Alliance for Community Health Centers. So that would be one example of trying to join other collaboratives within your state or within your region to also learn and implement new strategies and gain more knowledge. And if you'd like to, you could also request expert consultation just as a second opinion, or try and help identify what is working and what's not. So you can request NCUI technical assistance, and the form link, Mark can drop that in the chat box for us. So if you ever have a question about a process within your facility, please feel free to ask us for an evaluation. Next slide, please. One tool that I want to leave you with, and I know I only have about 2 minutes here, but one of the evaluations, and you might know of this already, is the governance of quality assessment. So it was developed to support trustees and senior leaders of health systems in your oversight of quality of care by defining core processes, culture, and commitment for excellence and oversight of quality. So they do parse it out into 6 categories, which are listed here. The thing that I like about this is they make it very straightforward. Prioritize quality, keep me safe, provide me with the right care, treat me with respect, help me navigate my care, and help me stay well. Once you guys do perform the assessment, you would then use those results to plan your next steps. Next slide, please. So some tips to stay engaged and refreshed as a board member. Definitely start thinking about your orientation. Make sure that you are also including that in the staff orientation as well. Have the staff get to know who you are as board members as well. Just one slide and kind of what you do would be great. And then also your own board of directors orientation. Have you guys looked at how you disseminate your bylaws, your roles and responsibilities? What does that look like for continued education for your particular board of directors role? Reading articles, looking at some board portals, the board retreat, and making sure that there is an element on quality, taking a look at what's happening within your organization, knowing how many patients you're seeing monthly, knowing how many patients are being referred out for care. What does that loop closure look like? You guys can should add again an element or a track on quality. Also, taking some ongoing educational training and also certifications would also be a really great way to stay refreshed. Next slide, please. And so I wanted to leave you with a little Spider-Man quote, of course, with great power comes great responsibility, and that is on your plates, of course, as boards of directors. So some additional superpowers to add to your repertoire. These are some really great books that I would recommend that you read. The Culture Code by Daniel Coyle. It's an amazing book that talks about teamwork. Leaders Eat Last by Simon Sinek, another really great leadership book that you could share with your organizational leadership. The Five Dysfunctions of a Team, if you've not yet read that, that's just so amazing. It talks about everything from, the non-participatory team member or one that's very aggressive. It also provides you with ways and tips and tricks as to how to handle those types of conversations. Better by Dr. Atul Gawande. He's probably one of my favorite authors. He goes into better about how do we achieve better healthcare? What does that look like? The HQ Solutions resource for the healthcare quality professional. That is actually a book in which, if you are going to take in the right category the certified professional in healthcare quality certification, that is a really great book that goes over how to provide data in a way that tells a story, which data to select. It also talks about some safety elements, the QI elements as well. So it's a really great book just to buy and to put into your organization's library. If you don't have an organizational library for leadership or executives, I would highly encourage you to create one. We did that as well over at Native Health, and staff could check out those leadership books as needed. And I just thought that it was a really great inclusion to share that wisdom and that knowledge. And then again, those certifications are listed there if you want to go into the IHI Open School certification and take their courses as well. Lean Six Sigma is also a really great quality certification, and the project management professional. Yes, and thank you so much. I am receiving some private messages. So yeah, proud to say that our board SNAC has well-rounded representation of board members, including legal, financial, COB members, higher education, and tribal leadership. That is awesome. That's a really great, well-rounded board. And I think this actually takes us into kind of our Q&A, mini Q&A session, but the PowerPoint will be made available. Mark will go ahead and also drop that in the chat box for us, the link to where you will be able to find that, as well as our other sessions. There's 6 sessions in this series, so you guys will also find that there. Next slide, please. And here's our knowledge check. Even though I did not get any responses as many responses as I'd hoped for in the chat box, I'm hoping that I can get some post knowledge checks here. Again, the answers were interspersed throughout the presentation. So I'm hoping for 100% all across the board this go round. I know you guys can do it. And I'm hoping number 4 is also still a 100%. You know that our team is here for you all anytime that you need in whatever topic that you might need assistance on.
There's a 60-second time limit on this, so you got about 30 more seconds.
Thank you so much, Mark. And it was definitely a pleasure speaking with all of you tonight. We definitely appreciate your time and know it's a lot to ask, at 3 o'clock, at least on the Pacific time, and then 6 p.m. on the East Coast time as well. So thank you, everybody. I'm going to go ahead and turn the mic back over to Mark.
Thank you, everyone, for your time and attention. And of course, great deal of appreciation to Zep Fuller for a very informative, information-laden presentation.